Awesome. Thank you. Well, good morning, everybody. My name is Ben Bohanowitz. I'm the Director of Client Services here at EBS for a full service brokerage firm, risk management. I have with us today Phil Baker, who is the CEO of Halo Scripts and really a phenomenal partner for us when it comes to pharmacy management. For those of you that are unfamiliar with Phil Baker, he's got quite an extensive background in the pharmacy space. He ultimately started in the retail pharmacy world working with a very well-known grocery store chains and evolved into a space of managing pharmacy for a regional hospital and center. He then moved on to start one of the first membership-based pharmacies, working with uninsured and underinsured patients, really for the way of changing healthcare for those patients to be more affordable and ultimately more accessible from a pharmacy perspective. And he's a wonderful partner of ours when it comes to Halo Scripts, which is our employer-facing program designed to get very accessible medications at a very low cost. And today we're excited to be on the many aspects of our webinar series here, which is prescription adherence, one of the biggest problems in healthcare. For those of us that have participated in our previous webinar series, I appreciate you returning back here. If you're interested in seeing any of our previous webinar topics, you can find them on our website or often posted into our social media pages. But without further ado, I will get things kicked off and hand it over to Phil. Phil. You're on mute, my friend.
Thank you. Appreciate that. Nice. So thanks, man. I really appreciate the introduction. I'll just take a moment to say thank you to everyone for attending. These webinars have been very well received, and we're seeing that attendance go up, and it's been just really exciting and unexpected. So thank you. With that, I'll turn off my screen and we'll jump right into the presentation. So the agenda for today are to kind of go over some key definitions in terms of adherence and the context we should think about prescription adherence, the importance of prescription adherence as it relates to its impact on the U.S. healthcare system and its impact on employer-sponsored insurance plans. And then we'll discuss some different strategies that payers can use to improve medication adherence, and then leave plenty of time for questions and answers. We always try to kind of make these really quick so we can get right to the questions. So the definitions. When we talk about prescription adherence, we need to understand that we're kind of speaking about a cascade of different umbrella terms. The first one being patient concordance, and which is the patient's relationship with healthcare physicians. Essentially boils down to, does the patient have consistent access to primary care, working with physicians? Beneath that, we talk about medical compliance. Once the physician relationship is established, is the patient willing to be compliant? Are they willing to make the lifestyle changes that may be necessary to improve their health? And then we get to prescription adherence. So then we get to the meds, and prescription adherence is a measure of the extent to which the patient's behavior matches what the physician prescribed. When it comes to prescription adherence specifically, if you go to the next slide, please. In the literature and kind of in pharmacy, we don't have a great measure for prescription adherence. What we use is based on when a prescription is refilled and the day supply that was refilled. So the measure is called a proportion of days covered, and it measures the number of days that the patient should have had a drug on hand, meaning they had a refill on hand, divided by the time interval you're looking at. And generally, when we talk about a patient, are they adherent or not adherent, we're referring to a PDC of 80% or better for all medications except for antiretroviral HIV meds, which they bump up higher to 90%. Again, this tells you that the prescription was filled and the patient, theoretically had it in their house, but there is no measure of what the patient actually does. And PDC is just a really broad, the 80% adherence is really kind of arbitrary. I did the math this morning, and a person could, in a single month, they could miss 6 days of treatment out of 30 and still be considered adherent. In a 90-day period, they could miss 18 days out of 90. And that seems a little too lenient. But again, that's the best we have. Some barriers to prescription adherence are, obviously cost is always an issue, but that aside, just starting with, does the patient even believe this prescription is going to work for them? The perceived lack of belief. If they take it, are there expected side effects that they're just not going to want to deal with? Are they going to be required to take something 3 times a day? It's just unrealistic with their lifestyle, different routes of administration, different condition-related barriers. And then just in a lot of areas becoming more increasingly a problem with pharmacy deserts, just access to even fill a prescription at a pharmacy. So barriers that we think of automatically would prevent a patient from even starting a prescription. On the next slide, there's equally just as much trouble for patients who do get access to their prescriptions. So the really complicated patients take 5 or 6 prescriptions. With the increased prescription prices, we find a lot of times that patients are having to fill their prescriptions at 2 or 3 different pharmacies to minimize their out-of-pocket expense and manage prescriptions at multiple pharmacies. And then compounding that problem, we find that usually there's one person in the household that's managing all the prescriptions for other household members as well. And so all of this communication that needs to happen between these pharmacies and the doctors falls on a single person, and it just falls apart. It's just completely overwhelming. So some behavioral and kind of reasons for prescription adherence. What happens when we see prescription adherence, decrease when it's bad? Well, the worst adverse drug event is no drug at all, never even addressing a condition at all. But once the patient gets a prescription, they could get the wrong med. They could take the wrong dose. They could take 2 pills when they're supposed to take 1. Wrong schedule, take it 3 times a day when you're supposed to just take it once a day. And then just natural, harms caused by the medication, side effects and allergies. All of these add up to failure, what we call failure of therapy. And that's essentially the physician saying, okay, this drug isn't going to work for you. It's a real problem in healthcare, because if you're not taking your medication properly, how do we really know that the drug didn't work for you? So the prescription adherence leads to increased adverse drug events, and those increased adverse drug events create a cascade on the next slide of costs that just compound due to patients either not taking their prescriptions or taking them improperly. So you'll have the adverse event. Let's say a patient with high blood pressure isn't taking their medication. They wake up in the morning, they feel dizzy, they know they can't work. They're going to call into work that day. But because they called into work that day, now they need a note. So they need to go to the urgent care to see somebody to get checked out. They get to the urgent care and they find their blood pressure is 180 over 120. It's ridiculously high. The urgent care has no option but to refer them to the local hospital, the emergency room, which will have to admit them until they get their blood pressure under control. Once that person gets out of the hospital, they still have a prescription adherence problem. They're much more likely to end up back in the hospital again. And so you can see how just not having a prescription creates 10 times the problem, the cost that it would be to treat it. And these total healthcare costs just are a super big problem, quite simply, in America. So on the next slide, this cascade, the impacts on the U.S. healthcare system, we're seeing estimated between $100 to $300 billion a year. 50% of those treatment failures I mentioned caused by adverse drug events due to poor prescription adherence, 25% of hospitalizations, and at least 125,000 deaths per year. So the impact on healthcare broadly is immense. On the next slide, when we look at the impact for employer-sponsored insurance plans, we see kind of that same cascade. You see reduced workforce productivity, and, people are calling in sick, increased healthcare claims, their costs go up, and ultimately, year over year, you're going to see your healthcare insurance costs go up, which is exactly what we've been seeing happening. Prescription adherence, super simple solution for a very, very expensive problem. On the next slide, we found, what does it actually cost? And so in preparation for this webinar, we did some research and ran across this article. and which specifically addresses that. And what they found was overall poor prescription adherence cost the payer about $157 per member per month more than an adherent patient. That's broken down though. So for an outpatient, it's $43.49 per member per month. And you can think of that as the kind of the person, the example. But once they enter the hospital, even just once, then those expenses go up to $127.57 a month. The really interesting thing to point out here is that non-adherent patients, their drug costs were lower because they didn't fill their prescriptions. And so we can see those drug costs here were $12.69. And the resultant effect of $13 worth of drugs is $157 per member per month. So the adherence problem, again, the solution is much more inexpensive than the total cost of the effects. On the next slide, so what do we do about it? What can we do to improve adherence, and how can we affect our plan? And really, you need to think about three categories. One would be medication access, physician access, and pharmacist access. So in terms of medication access, your plan design, what do your copays look like? If you're on a high deductible plan, do you have a lot of people that spend $4,000 a year on drugs, but not $5,000, so they never meet their deductible and they're really, paying a ton out of pocket? If you have copays, what do those copay structures look like? Are they, reasonable? How many people are, really not filling prescriptions due to the copays? A lot of that can be addressed in the design, as well as incentivizing good prescription adherence. That has to go along with increased access to primary care. So just having an insurance card and a network is not good enough anymore, quite frankly. There's too many other resources, and we'll kind of hit on that on the next slide, but there's all sorts of direct primary care. Different RNs are kind of getting into it now, and there's just a million different ways to reach a primary care physician. And then medication management, involving a pharmacy team to actually manage your prescription spend and manage the patients and make sure that both improve. Those are the kind of the three pillars, if you really need to be thinking about in terms of strategy. Going back to, on the next slide, please, the technology. So increasing access to primary care. There's, from the pandemic, telemedicine is huge now. Urgent care, primary care can all be offered virtually, access, right from the patient's phone. As well, kind of what's happening at the same time is we're seeing that all the different biometric devices like a scale, an O2 reader, or a blood glucose machine, that data can be sent to your phone and saved on your phone. And the medical team can access it to enhance the access of your care. So all of these things, technology is really coming along a long way and should be considered as a large part of your strategy to your own benefit. And so the next slide, please. So the medication management program, what does that really look like? And so for us, that's a concierge pharmacy team that's available 24/7 to the plan members to help them with all things pharmacy. Quite literally, anything that we can speed along or help them solve is what we're there for. The job of our team is to keep all the prescriptions on the same set schedule. That's how we improve medication adherence. So our patients are not getting 30-day fills. They get enough medication to last until the next ship date. And then on that ship date, all of their medications are refilled and sent in a single box on the same schedule. That sounds really simple, but it's really hard to pull off. So you think about a complicated patient is usually seeing 4 or more physicians, taking 8 or more prescriptions. We have to work proactively with the physicians to get not the refills they need right now, but the refills they're going to need next quarter for the next batch. And so it's very high touch, let me say that. The patient aspect of it is literally trying to make everything as easy as possible for the patient to take over all the communication between the physician as much as they want us to, and just take that pharmacy problem off their plate. And so on the next slide, you'll see we did a case study for one of our very first clients, and it was a small group of people over a really long period. So synchronizing all these patients to quarterly fills means you only have 4 data points a year. So we looked at 3 years worth of data on 34 patients. And what we found ultimately was, number one, we improved their PDC, which was already good, to 100% for cholesterol meds and 98.1% for diabetes meds. And we saved the company quite a bit of money. Overall, it was 35% reduction in their top line pharmacy spend. Just by maintaining these patients, keeping them on a set schedule, making sure they had the medication they needed when they needed it, and that they were taking it properly. What the study didn't look at, the savings were purely in terms of the pharmacy spend. The next version of this will look at avoided sick days and emergency room visits and hospitalizations. Those things just take much more time to get the data to make significant, but it shows that the management program can have a huge effect on your pharmacy spend. So next slide. So calls to action, what can you do about it? If you're called in today and you're interested in learning more, the first thing is take a look at your pharmacy claims and get an idea of how adherent your group is. You can do that by looking at the percentage of 30-day fills or less than 30-day supply fills versus the total 90-day counts and so on. Understand your plan design. Take a look at your plan design and see how you're kind of doing with the prescription access, physician access, and pharmacist access. And then consider new strategies to improve areas where you may be weak. If you need any help with any of those things, then we're available to help with that. And so that is right under the wire, about 20 minutes, as quickly as I could do it. I would love to answer any questions that anybody might have about this or really any other pharmacy topic.
Awesome. Thanks, Phil. So team, as you're potentially preparing for some questions here, either through the chat or if you'd like to come off mute, we can certainly answer them that way. But I think the biggest opportunity we see, especially working with some of our self-funded employers that have rolled out a medication management program or have modeled a plan design or increased access, is that people generally have an opportunity now to remove all the barriers that typically presented themselves with prescription adherence, in the sense that it was either a cost or lack of understanding. So proper plan design and the right access to a primary care for the need and understanding of that medication certainly improves that. But they really have an opportunity to interact with those team members who are going to be responsible and accountable to making sure that prescriptions are taken on an ongoing basis. I know most of us may have had an example in the past where maybe you walk into your primary care provider, you see them for less than 10 minutes on an annual basis, your blood pressure, cholesterol may be high, they're, producing some sort of medication saying, hey, I hope you take this. And then you see most people say, well, I don't think I need it, or I don't feel like I'm paying for it. I don't know if there's a result, makes me feel weird. And by and large, you see a total breakdown of what should be happening in terms of prescription adherence really fall flat. And so when you properly align primary care access for people to understand why there's a need there, potentially create or craft a better plan towards managing a specific chronic condition, or on the back end, if they do need to take that medication, making it more financially available to them and more accessible through things like mail orders. So you're not going to the pharmacy every other week, especially for those medications that need to be taken on a regular basis. It significantly improves not only the employee experience, but it also presents an opportunity for your plan to perform much better from a cost perspective. And so we really see the improvement of medication adherence, prescription adherence, come full circle for everyone that's involved. It's better for the provider, it's better for the patient, it's better for the plan and the payer. So with that, team, any questions on anything we reviewed so far? Any questions overall from a pharmacy perspective? So Phil, we got a question that comes in. So the employees who are taking psych meds often have trouble with insurance carriers dropping meds from their formulary. Any suggestions on how employees should speak with their doctors about options?
That's where, yeah, we bridge that gap. Well, that happens not just on psych meds, but all kinds of meds anymore. We can bridge that conversation. We can let the patient know, number one, what the other options are in most cases, depending on what they're being treated for, what best option number one is, what second best option number two is. Kind of explain those to them in terms of pharmacy, in terms of side effects and what they would expect. And then if the patient says, I want to do, drug number C, we can drug number C, the third one on the list. Then we can call the physician and request a prescription, that prescription directly. We can save the patient the trouble of having to request it from the physician. And then also, the other piece we do is all their other physicians, now their meds just changed and they see a bunch of physicians. How are we have to inform them that they're on a new med as well.
What other questions do we have, team? Phil, sounds like what we presented here was fairly comprehensive. I haven't had too many questions that come to the gate here. We'll certainly be able to share this recording for anybody who'd like to see it again. We'll have some follow-up materials with the slides as well, if anybody would like to preview those on their own. But I appreciate everyone carving out time. As we kind of mentioned in the beginning, these are intended to be short and sweet and to the point. You can get in and out, understand potential problem, understand a solution, any tweaks you can make on your own. If you're looking for additional information, either about how we assist with plan sponsors and helping to structure plan design, improve access to care, or pharmacy solutions, certainly don't hesitate to reach out. And you can also reach out to our folks over at Halo Scripts to information more on their medication management program. But again, I want to thank everybody for joining here today, and we'll see you for our next portion of our webinar series in the new year. Thank you, everybody.